Yes.
I got two questions. So if you're going to do surgery, is it just a simple X-ray, or you get a scope first? And then the other question, finish what you were saying about how long these things last. I heard 15 years.
Yeah.
You started to say 20 years.
Yeah. Well, the question about scoping it, many people that are having knee surgery or considering knee replacement have had a scope. If they haven't, you can really tell from X-ray, I would say the vast majority of the time, what's needed. I mean, if your arthritis is so mild that it doesn't show up on X-ray, then I'm not going to recommend a total knee replacement. I'm going to recommend a scope first. But if I see your X-ray and the bones are touching one another and you've got bone spurs everywhere, yeah. Yeah.
I think I have ACL, I got arthritis,
Yeah. Yeah. Yeah, if that's the case, an MRI might be helpful. A scope may be necessary. It just depends. But I'd say the majority of people that come to me seeking advice about a total knee replacement are pretty much ready for it. The ones that aren't, we do a lot of scopes. I mean, I scope 350 knees a year, so I do a lot of scopes. But it's not always necessary for knee arthritis. And the other question was how long they last. That's a really good question. I mean, the data that's out there on the total knee product that I use is now 20 years old. So we know that 85% of knees will last, or actually more than that, will last 20 years. So you could be in that 85% or you could be in that 15%, but we would expect it to last 20 years or more. The partial knee products, we don't know. I mean, we hope that they'll last a long time. And I tell my patients that I honestly don't know. Nobody knows. We anticipate that they'll last 15 to 20 years, but nobody knows. Yes?
I am one of those people.
Okay.
And I've had DVTs in the past.
Uh-huh.
And now my knee's blown out.
Huh.
So what kind of, I know that I'm extremely risky for DVT and
Yeah.
Yeah. But I'm also in a walker.
Yeah. Well, she's had a DVT, which is a blood clot. Everyone, regardless, not just you, everyone that has knee replacement at this hospital receives anticoagulation after their surgery for at least 2 weeks to minimize the chance of a blood clot. So we either give you blood thinning pills or we give you blood thinning shots. And so that's given regardless. If you're a high-risk patient, like you obviously are, there are lots of options. We can put in a filter into your vena cava, the main vein in your body that can block DVT. So even if you got one, it wouldn't be a lethal DVT, it wouldn't kill you. If you did get a DVT, a clot, and it broke off, it would get trapped in the filter that's in your body. So those are options that we usually discuss in conjunction with the pulmonologists or the experts in the treatment of blood clots. But there are options for you. It's not a lost cause. There's definitely options for you. Yeah. Yes.
I have a stent put in it.
Yeah.
They affect knee surgery?
Now, if your stent is 6 months old or older, the cardiologists usually don't mind us doing surgery.
Mine is
Yeah, that's perfect. Many people that have had a stent do take anticoagulants. Plavix is the big one, or aspirin. So we usually have to negotiate with your cardiologist to try to get you off the Plavix for a few days ahead of time so you don't bleed so much. But brand new stents that have been placed recently, you can't have surgery because they have to anticoagulate you so your stents don't clot. If you have an older functioning stent that's been in there a while, that's generally not a problem. Yeah. Yeah, a lot of people do. Those are questions that are really up to the cardiologist. Pacemakers hardly ever disqualify you from having surgery. We just usually like to get your cardiologist informed and on board so that if there were an issue with it during or after surgery, they'd be immediately available to help. But pacemakers, although it sounds like it would be a disqualification for having major knee surgery, is generally not a problem. Yes? Yeah. Uh-huh. Oh, where you do the rehab? Well, you mean where do you do the rehab? We do the rehab here at the hospital because we're familiar with the physical therapists and they're familiar with us. In general, it's a 3-day a week type of thing for usually the first month and possibly 2 months. After that, we decrease the frequency of the rehabilitation depending on your progression. We have some of our therapists with us. Ron, do you have any comments to add to that?
No, I think that's fairly accurate. About 3 times a week for the first month. That one of our our 2 outpatient centers at the hospital is typically what we see
Yeah.
in the first month. Occasionally, if appropriate, we decrease the frequency for the second month to try and lean to more of a home inject.
Ron's our director of physical therapy, so he would know. Yeah, that's typical. I mean, everyone progresses at a different rate. It is time consuming for the first month, and if you don't devote the time that's necessary to rehab your knee, you are many times disappointed with how slowly it progresses. So you have to devote at least that first month to doing it, and then after that, we generally have a very good feel for how things are going. If they're going well, we decrease the frequency. If they're not going well, then we continue it and until you are doing as well as we hope you would be. Anything else? Yes?
All surgeries are done at this hospital?
Yeah, I do 95% of my surgery at this hospital. I also work from time to time at Methodist Willowbrook Hospital.
I'm concerned that I have good patients.
Yeah, well, that's one of the reasons why that's one of the insurances that we have a difficulty with here. I enjoy working at this hospital because we have a dedicated joint replacement department, which no other hospital in Northwest Houston has. If you have the opportunity tonight or some other time, on the 4th floor is our total joint center. Everyone up there has had a knee replacement or a hip replacement. Most of the patients up there have come to a preoperative class, which is run by Joe Bailey in the back of the room, right? Don't you run that? And so before your surgery, there's lots and lots of questions, and you don't always get all the answers you want from the doctor. I mean, I try to inform you as much as I can, but there's lots and lots of questions. So we have a class every week, and so we invite everybody that's having surgery to come to the class. You sit down for an hour-long presentation, slideshow, handouts, question and answer, and all of the stuff about what do I eat, what should I wear, what should I bring, is it going to hurt, all that stuff gets answered by Joe. And so generally by the time you get there ready to go, you're ready for it. So, yes?
Do you anticipate rationing with the new health care? I guess most of us are here on that.
Yeah, yeah. I don't know. The health care bill that passed last fall was 2,100 pages, I believe. I forget the exact. Yeah, nobody knows. The legislators that passed the health care bill, by their own admission, hadn't read it before they voted on it. So nobody knows. We're trying to figure it out as we go along. And even the stuff that we think we figured out, when we have teams and teams of lawyers here and in Washington that advise us, and they have differing opinions. I mean, it's open to interpretation. So I think that's a piece of legislation that's in evolution, and nobody knows the answer to that.
Maybe a medical decision will be delayed because of this thing.
Yeah.
And those of us who are in our 70s, we may be saying you're just too old for this.
Yeah. I don't know how you can pass a health care bill of that magnitude and of that type of expense without rationing health care. There's not the money in place to support unlimited access to health care. And the treatment of arthritis is one of those things that's not life-threatening. So nobody dies from knee arthritis. So if anything's going to get cut, it would seem to me, if you're a legislator, you're going to keep treating cancer where people die, and you're going to keep treating heart attacks that people die from, and diabetes and strokes. And you may have to start rationing the so-called elective things like knee replacement that people come in for. So I don't know the answer to that, but that would seem reasonable to me. Not reasonable that they're doing it, but reasonable that that's what they're going to do.
What does Medicare pay compared to what your normal charges for those that are not on Medicare?
Pay me?
Yeah.
Medicare typically pays about 1/4 of our typical charge.
And it's being reduced, right?
Right. Yeah, many doctors have stopped taking Medicare. I have parents and grandparents, and I can't see not taking Medicare for people that have waited all of their life to finally get Medicare. So I like getting paid for my surgery, and I'd like to get my fee, but I still accept Medicare. But they don't pay us very well, and they're starting to pay us less and less. Well, thank you once again for coming. It was a pleasure talking to you, and nice seeing all of you out here. I recognize a lot of the faces in the crowd.